Hello, good afternoon, everybody. First off, I just want to say happy Native American Heritage Month. Ya'at'eh shekeh do shebene'eh, she'e Karina Sabiku Yunishe, Tachitni Nishle, Hawaklana Bushishtin, Toglini Dashache, Ma'idishkizni Dashanele, Akot Ego Dine, Atsane, Nishle. Good afternoon, my friends and relatives. My name is Karina Sabiku. I'm Dine and Hemus Pueblo. I'm from the Red Running Into the Water clan, born from many Hogans. I'm a senior research program coordinator under the Center for Health Equity and Community Engaged Research at Mayo Clinic in Rochester, Minnesota. Welcome all to the Indigenous Health Topics speaker series. I'm happy to have you all here today in person and virtually as part of our center's Native American community outreach efforts to engage tribal health in Minnesota. We host this event, which is focused on hosting speakers who are local, regional, and national experts in health, education, and research. These presentations are focused on topics that have an impact on our Native American, Alaskan Native communities. There are future opportunities to attend in person and virtually. All our presentations are recorded and posted on our internal and external websites. I just want to thank you all for joining us today to listen and learn. I'll be going over a few housekeeping items. So we will have time at the end of the presentation for questions and answers. Please add your questions to our Q&A or chat, and we will get to them at the end of the presentation. Today, I would like to introduce our guest speaker, Alec Kalec. He is Pamaban and Muswano Indians and is a MD PhD candidate at UC San Diego School of Medicine and Herbert Wertheim School of Public Health and Human Longevity Science. He works collaboratively with the Global Health Policy and Data Institute on research projects integrating social media, health technology, health policy, and tribal public health. He is also interested in medical education and workforce development. He currently serves as the national president of the Association of Native American Medical Students. In 2022, he was named a 40 under 40 leader in minority health by the National Minority Quality Forum, and was also chosen to participate in the White House Leaders in Health Equity Roundtable Series. Please welcome our guest speaker, Alec.
All right, thank you so much, Karina. Hopefully everyone can hear us. Please, I guess, place in the chat if you can't. Miyuyam, Latong Alec Kalec Kitan, Nataf Kamangai. Hello, good morning, good afternoon, everyone, depending on where you're calling in from. My name is Alec Kalec, and I'm super excited to be here in Rochester, Minnesota. My body is maybe not as excited given the cold, but happy that Mayo definitely has some nice heating and ventilation here in the facilities. I kind of feel that I'm revisiting Mayo Clinic because I interviewed here for MD PhD programs, but ultimately chose UC San Diego. Can't necessarily say it was for the weather, but the weather was certainly a very strong factor, as well as returning home, where I felt that I could be both a medical student, a graduate student, as well as a community member, and work to be responsive to the needs of my own tribal community. As Karina introduced, I'm now in the 5th year of my MD PhD program at San Diego State and UC San Diego. And I really work on understanding the health policy landscape that affects Indian country, as well as the status of data, or the lack of availability of data as it relates to responding to issues that affect tribes and tribal health organizations across the country. So when thinking about the impact of COVID-19 in Indian country, it's actually going to be the second half of this talk because I feel that we need to kind of get a primer on policy, health systems, and understand many of the key factors that went wrong, or, and some would say we're going just fine, but ultimately led to a detrimental response to COVID-19, a insufficient response from the federal government, but certainly strong responses from tribal communities who. For the audience, is that working for everyone?
Yes, that sounds great.
Okay, I see a clap. Okay, well, I don't know how much you've heard earlier, but we're going to talk about a lot. We're going to talk about a lot of policy, and I hope that throughout the presentation, you'll take away something of importance. Before I really get started into the content of this presentation, I just want to share that I'll be using a lot of terminology as it relates to Native identity, that being terms like Indigenous, Native American, American Indian, recognition or the lack thereof, blood quantum, tribal membership, trust responsibility. These terms are not, interchangeable. They all have different legal meanings, social meanings. If you ask one person, they'll tell you what they prefer. If you ask another, they'll tell you what they prefer. And that's all to emphasize that Native people are not a monolith, and it's always wise to ask an individual or community how they want to be represented. The legal name for my tribe is the Pama Waima Band of Mission Indians. The common name is the Pama Band of Liseño Indians. Our traditional name is the Peyomkawicham, or the People of the West. So depending on, in what kind of space I'm in, it makes sense to use one term, and others it makes sense to use the other. So just a note there. So when thinking about a kind of Western conceptualization of health, I think many people would say the absence of disease is a picture of health. But for many Indigenous communities, as well as other marginalized groups across the country, health is much more than the absence of disease. It represents the relationship or interconnectedness between many domains of health, such as spiritual, physical, mental, emotional, and for some, you may kind of think of a pie representation where a certain domain is more important to one than the other, but the relationship between these domains is very important to an overall representation of health. And when we think about things that disrupt those relationships, you can think about how it can have an adverse impact on physical health, psychosocial health, and how you'll learn later on that I kind of really represent the disruption of Indigenous knowledge systems as foundational to the health inequities that we see today across Indian country. A kind of researcher's representation of health from the National Institute on Minority Health and Health Disparities kind of helps represent how in the kind of medical and social world that we may think of individual behavior as a key determinant of health, but really individual determinants of health are really just one kind of domain or one kind of aspect of a much greater picture of health when it relates to interpersonal, community, and societal levels of influence, as well as other domains of influence ranging from the biological and the behavioral all the way to healthcare systems. And perhaps the two most important domains that I'll kind of compare and contrast throughout this presentation are the kind of top left and the second from the top right, which are biological vulnerability and mechanisms and policies and laws. Because for Native people, our health has certainly been politicized for us. And I really want to refute notions of racial essentialism, or really saying that it's our own choices and behaviors that determine the kind of poor health status of American Indian communities, when in reality, it's the disruption of our traditional ways of knowing, as well as policies and laws that operate at the kind of local, state, and federal level that have a negative impact on our means of self-determination, self-governance, and being able to really exert full control over how we live our lives. And when thinking of the level of which we're kind of gathering as medical research scholars, we all know that theories like critical race theory are really reserved for settings of medical school, law school, and higher education programs. And Arizona State University scholar Brian Brayboy posits critical race theory as a kind of key influence on how policies and laws determine American Indian and Alaska Native health. And when you take a framework such as this from the NIH, but then place the first tenet of tribal crit at the bottom, it really provides a way at looking at how colonization is this kind of foundational driver of health disparities and how it is endemic to society. So we can't look at any of those domains without first acknowledging that contact, colonization, and the centuries afterward really are the kind of key foundational driver of these disparities, because you see kind of shared disparities among different racial and ethnic groups. But when you think about the underlying etiologies of those disparities between groups, they're certainly not the same. This is an adapted framework of what we just saw on the previous slide from Dr. Sparrow Manson at the University of Colorado that really replaces each of those squares with concepts and structures and measures that are very specific to American Indian and Alaska Native communities as a whole. Again, really thinking about biology and policies and laws for the sake of this presentation, when in reality, each of these squares could be its own kind of lecture in itself, because each of these issues are not independent. They're related when we think about how American Indian and Alaska Native patients access care through their community, through a traditional healer, as opposed to the Indian Health Service, as opposed to a community or nonprofit hospital, whether or not they have insurance, whether or not they have access to food or live in a food desert, whether they're in community. But there are also factors outside of their control, such as occupational or community exposure. So thinking of the Exxon Valdez oil spill, the Gold King mine water spill in the Southwest, and how water is often not accessible to our communities. And that creates a barrier or kind of a reliance on other people in order to get the resources that we need to take care of ourselves. And when thinking again about policies and laws, there's really no shortage of those that influence health. So whether it be indigenous data sovereignty or the ability of a tribal government to regulate their affairs, whether we see our own students go on to health professional training and be asked about kind of federal assimilationist structures such as blood quantum, how we compare federal health programs like the Indian Health Service and the Veterans Health Administration, and see how virtually all physicians that are trained today will have exposure to the Veterans Health System, while almost none of them will have exposure to the Indian healthcare system. And then the final square, the Indian Child Welfare Act, which is currently being litigated upon before the Supreme Court, which will determine the political status of tribes and whether tribes have the ability to oversee child welfare placements in our own communities. Billing for traditional healing services. So while the kind of traditional health model says the absence of disease is an optimal picture of health, for Native people, being able to be connected with culture and traditional healers and consultation, with a more Western provider is a way of prioritizing different aspects of health. But unfortunately, the federal government does not authorize payment for traditional healing services, and other payers such as private insurers, Medicare, Medicaid, do not pay for these services. Indian Medicaid managed care. So you'll see how the Indian Health Service relies increasingly on third-party collections, but state managed care organizations do not pay Indian healthcare providers at the same rate as they do others in violation of federal law. The Special Diabetes Program for Indians, Tribal Public Health Authority, electronic health record modernization, or really an antiquated structure that furthers disparities in data collection, voting rights as a determinant of health, access to substance use treatment, cultural leave for trainees, and all these other factors. And, while I would love to cover all of them, this is just to say, here are, 4, 8, 12, 16, 19 squares. There can be over 190 squares. And these are all important issues for Indian people. But when our population as of the 2020 census is about 2.9% of the US population, it becomes easy for jurisdictions to prioritize the 97% over the 3%, even though these jurisdictions have a legal obligation to provide services to our communities in response to our needs. And when looking at this point of time now and looking back in the slides to come, the American Indian and Alaska Native population experienced the largest decline in life expectancy between 2019 and 2021. So while all groups lost years to their life expectancy, our people suffered the worst of that burden. Not due to any one factor, but due to a kind of perfect storm of factors, largely driven by COVID, the opioid epidemic, but also just inadequate infrastructure to adequately take care of our health. And when you see these numbers, I think, one would say, well, the United States spends so much on healthcare relative to other nations. Why is the life expectancy of the general public lower than other nations that spend less? But then you have to go a step further and say, well, you have to think about how they don't even spend the same for each of their federal healthcare programs, where they actually spend even less on the Indian healthcare system. So when you're expected to do so much with so little, how can you expect an equitable response? And I'm thinking again about foundational drivers. Perhaps we can take everything into different buckets and say, the kind of key kind of drivers of health disparities over the last 5 centuries are contact with non-native settlers, those who really dehumanized us and were empowered by religion and motivated by greed to take something from us rather than work with us, how government programs such as commodity food programs gave supplies that allowed people to live, but did not allow them to live healthily when we consider the higher caloric content and higher just overall poor nutrition profile of these foods, and how federal policy isn't even consistent from decade to decade, century to century, where we start from a goal of outright genocide, eventually to kind of cultural assimilation, cultural genocide, and then now, as of 1975, to a point of self-determination and self-governance. Another way of looking at what was lost in order to understand what determines health is land. And it's not controversial to say our land is our health, and being in relationship to the land and the environment is a key determinant of Indigenous health. On average, Native people from across North America were forced to migrate. Migrate makes it sound voluntary. They were forcibly removed under duress, an average of 239 kilometers. The maximum forced relocation distance was close to 3,000 kilometers. But when we look at every group as a whole, they were moved to lands that were on average hotter, drier, and had less mineral value potential. And tribes today only occupy about 1.1% of their historic land base. They're not in lands where they necessarily were familiar with. And for many of the communities that were relocated, they were also co-located with culturally dissimilar Indigenous groups, which often created kind of a culture clash. So again, perhaps these are some points some points you don't know. But the point, at least for this slide from Farrell et al., which was published in Science last year,
is that one, the land that we have now is much less than we have today. And two, not every tribe today has a land base, and that often relies on federal recognition, among other factors. But while there are 574 federally recognized American Indian and Alaska Native tribes in the United States, there are only about, I believe, 329 reservations. So when thinking about the stability that having a land base provides, especially as it relates to creating a healthcare infrastructure and education infrastructure, to have housing, these are all important influences on health that shouldn't be taken in isolation, but really have to be contextualized in a much larger picture. And finally, we get to the Indian Health Service. And perhaps it's a misnomer because the Indian Health Service, eventually its goal when it first started was not to take care of Indian people. It was to prevent the spread of disease to the non-Indian population. So it was a means of containment. It was an example of public health. But when you think about who the public was not Indigenous peoples. So the Indian Health Service has its beginnings in the Department of War before being transferred to the Department of Interior with the Bureau of Indian Affairs, and now in its present day in the Department of Health and Human Services. But of note, while the Indian Health Service is operated within the auspices of the Department of Health and Human Services, it's funded in the appropriations bill under the Interior. So the Department of the Interior and appropriations that go to those agencies take care of three things: Native Americans, land, and minerals. So even today, we see the kind of relics of federal policy where, again, we're still not seen as a people, we're seen as less than that. We're seen as, items, objects, something where people are curious to study us, understand us, and that creates a very kind of painful history that we're forced to live with, especially as some of you may have seen a press release from Harvard and their Peabody Museum about, I think it was on Thursday, announcing that they have 700 hair samples from individuals from over 300 tribal communities who were former students in the residential boarding school system. No one knows why, well, even the museum doesn't even know why they have them. But I think we all know why they have them. And that history is, again, part of a much larger picture of how we have never really been seen as a people. We've always been seen as a problem. But moving on, the Indian Health Service now has really grown to provide direct healthcare services as well as funds the tribes to operate their own healthcare programs. And this grew out of judicial rulings, executive orders, and other documents that formed or constitute this government to government relationship, or what's otherwise known as a trust responsibility. The Indian Health Service today has 12 service areas. The IHS itself, as a federal healthcare provider, has a varying presence in each of these areas. So if you take the Great Plains, Bemidji, Billings, the IHS is much more present there than they are in California, where virtually all healthcare facilities in California are operated by tribes themselves. You also may wonder why the Navajo Nation has their own service area when they are one out of 574 federally recognized tribes. That is because the treaty that the Navajo Nation signed with the federal government calls for a special healthcare delivery area specifically for their people. Another example of how treaty rights come into modern politics is this week's congressional hearing for a Cherokee delegate before the House of Representatives. So our treaties that are just as old as the founding documents of this nation are just as valid as those documents. However, the United States has broken virtually every treaty that it's signed. Other points for this slide are that each area has a different user population. and the number of facilities also drastically varies. So if you take recent estimates of IHS users for Nashville across the Eastern Seaboard and the South, and compare it to, say, Tucson, those have comparable user populations. But when we think about forced relocation and westward migration of indigenous peoples west of the Mississippi, then perhaps we see why Nashville has a smaller user area than other areas. If we zoom in on, say, take one service area like the Navajo Nation, each service area is comprised of service units, and each service unit is responsible for coordinating care between IHS, tribally operated and urban Indian health contracted hospitals, clinics, school health centers. So it's a very decentralized system, but in a way that may be kind of a strength in itself, where each area is able to determine its own priorities with its own funding levels. And as I said earlier, the basis for Indian healthcare starts with the United States Constitution and is built on a series of legislative acts and other rulings. Perhaps the most important for my own presenting tips and tricks is to bold the thing to remind the speaker. So again, the Indian Self-Determination and Education Assistance Act of 1975 marks the kind of formal end of federal termination policy and marks the beginning of a new system or new era of letting tribes decide what they want to do for themselves and giving them the resources to do that through mechanisms like tribal consultation with federal agencies. And one caveat there as well is also why I put Congress on the left side, is that there are federally recognized tribes in 35 states. So when thinking about the legal obligation that the United States has to tribes, all of that is done through legislation. However, there are 30 US senators and I don't know how many US representatives who do not have tribes as constituents. So trying to make a body responsive to the legal obligations of the US and remove politics from the equation can often be very difficult when trying to engage in good faith between tribal governments and the federal government across its three branches. The federal trust responsibility, as I said earlier, stems out of a variety of documents and establishes the basis for healthcare, education, as well as not just healthcare delivery, but the provision of physicians. And you can't just go to the Indian Health Service because you decide one day that you identify as American Indian or Alaskan Native. It relies on your affiliation with one of the federally recognized tribes in the US and the political relationship that entails that separates you from the racial identification of American Indian and Alaskan Native. When comparing facilities, I think in the news you see a lot about the Indian Health Service and how it operates, when in reality, tribes today manage more than half of the Indian healthcare direct care budget. So through compacts and contracts, tribes are increasingly taking control of their healthcare, and they receive the same amount of funds that the IHS would use to operate and manage programs in their community. But there are challenges that come along with that, which also will speak to why responding to COVID-19 was such a disaster. So despite these legal obligations, IHS is funded as a discretionary program rather than a mandatory program. So it relies on yearly appropriations. So while the IHS budget has steadily increased from year to year, that's really only been to address inflation rather than the expansion of healthcare services. Conservative estimates from the National Indian Health Board say that the IHS is funded at only about 56% of need. And when taking this low level of funding and the kind of uncertainty around whether they'd receive funding, this makes the agency and those that it depends on vulnerable to lapses in funding. So this was especially prominent during the congressional budget the phrasing escapes me, but the like the budget, the temporary budget process where there were continuing resolutions to receive funding from the federal government, but there weren't necessarily funds for the Indian Health Service. So many facilities were forced to drastically scale back the services that they provided, or tribes themselves had to infuse their own funds to keep doors open. Funding, again, not looking great. So between the Indian Health Service, Medicare, the VA, and Medicaid, the IHS spends the least per capita per patient. The IHS is also the payer of last resort. So if you are a IHS patient who also is enrolled in private insurance and other sources of funding, the IHS requires that you exhaust all of that funding before they themselves will pay for your healthcare. But you'll see on a future slide that insurance coverage for the American Indian population, especially by age group, drastically varies. So the IHS, again, is already asked to do so much with so little. But when you also deal with issues of, say, Medicaid managed care and getting reimbursement for the services that Indian healthcare providers provide, the IHS is often not receiving the appropriate amount of funding that it deserves. So those third-party collections, again, are an important source of revenue. I mentioned already that we've never really seen a budget that expands healthcare services in the IHS, only one that addresses inflation. And for third-party collections, which I've mentioned a bit now, account for more than 60% of some IHS and tribal facility budgets. So COVID-19 drastically decreased third-party collections, and the former director of IHS says that said in a hearing that it would take years, if not a decade, to recollect what was lost. So these are incredibly important funds, but also in thinking about how funding is structured and what population demographics look like, we can point out one important thing, which is urban health. So about 70 to 75% of the American Indian population lives in urban centers, yet less than 1% of the IHS budget goes towards urban Indian health. So when thinking about the factors that influence health based on the national, the NIH research framework, having a provider, a physician who understands your background, who understands your culture, language, your values, and kind of understands how you view health can be very important, but you often aren't able to receive that in urban centers. And then on the right, about a quarter of all American Indian and Alaska Native Medicare beneficiaries list the IHS as a source of coverage. So those enrolled in Medicare, do rely on IHS and rely also on other services. So the more funding, the better. And there is certainly a push to make sure that IHS patients are increasingly enrolled in public health or public health insurance programs, because that also brings in more dollars to your tribal healthcare facility. The Indian Health Service itself, so when it's forced to pay, has a system or a priority level system of how they purchase care. So when accessing medical or dental care away from an IHS facility, there are 5 medical priority levels. There's often funding to always take care of priority level 1, but when funds are exhausted for the year through the purchase and referred care system, IHS and tribal facilities are forced to ration care or limit it to cases of life or limb services. So while many facilities throughout the year, especially tribal facilities, can extend care to medical priority level 2 and some to medical priority level 3, which include specialty services, which include inpatient and outpatient care, you don't really see any facilities where you're able to extend care to medical priority level 4, such as services requiring rehabilitation or skilled nursing facility care. And you certainly don't see procedures that are considered purely cosmetic in nature, which involve plastic surgery. So thinking about disparities for American Indian and Alaska Native women with breast cancer and the ability to have breast reconstruction, that's considered plastic surgery. So, it's increasingly important to have more than just the IHS as a payer of your healthcare, because it limits the services that you're able to receive. And again, if you look at this chart from the Kaiser Family Foundation, you'll see that for the non-elderly, American Indians are less likely to have private insurance. Children are less likely to have private insurance. They're more likely to be on public payers and uninsured. And then for adults, a similar picture. So it's really important to understand the payer mix at facilities, but also make targeted outreach to increase coverage in programs that can't cover these services, because a report from the U.S. Commission on Civil Rights in I believe 2018 stated that in fiscal year 20, actually the report was in 2020, but it said that in fiscal year 2013, the IHS Purchase and Referred Care Program denied 150,000 requests for services through purchase and referred care, which amounted to roughly $1 billion in unmet medical need for IHS patients. I looked through the IHS congressional budget justification for fiscal year 2021, and lo and behold, despite an increase in the budget to purchase and referred care only by about a few $1 million, they denied roughly 150,000 claims, which amounted to nearly $1 billion in unmet need. So despite nearly a decade's time, there's been no improvement to purchase and referred care. And we're telling American Indian patients, we don't have money to pay for your care. So either fund it yourself or don't receive it at all, or receive it, but you may have to receive it later. As a social media researcher, I saw people on GoFundMe during the COVID-19 pandemic that were trying to raise money for their IHS care because their facility told them we're out of funds. So they're either forced to go to another facility or, again, pay thousands of dollars out of pocket without necessarily a promise that those funds would be reimbursed. When looking at vacancies across the system, we see the greatest disparities in behavioral health. For physicians, it hovers around 28%, but really just across the board, every discipline has significant vacancies. And this is at May 2020, so at the start, near the start of the COVID-19 pandemic, and only at federal facilities, because data for tribal and urban facilities is not necessarily available. For the past roughly 5 years, the IHS physician vacancy rate at federal facilities has stabilized at around 28%. Some would say this is a good thing, that it's not getting better, but I'd also tell you, or not, sorry, that it's not getting worse, but I tell you it's also not getting better. And I certainly wouldn't want the American healthcare system to, look like that line, because that would certainly be a national crisis. But again, issues that we view as a crisis aren't always seen as such by those who are not necessarily involved in the system. So we get to COVID-19 in the kind of closing 10 minutes of this presentation, and really trying to understand everything that was shared already and how that looks like in health outcomes for the American Indian population. So cumulative mortality through March 2021, so roughly a year of time in COVID-19, we saw racial and ethnic minority groups, more likely to be cases, more likely to be hospitalized, more likely to die. Indigenous peoples, again, were at the top. They remained as such through many months through 2022. And this isn't surprising, especially for Native researchers, because we knew that for H1N1, we had a 4 times higher mortality than the non-Hispanic white population. And for the 1918 flu pandemic, we also had 4 times higher mortality. So more likely to die, but also less likely to receive money to respond promptly to make sure that we're being proactive rather than reactive. And when you don't have an emergency infrastructure to respond, I mean, you can't necessarily organize a coordinated response. When COVID-19 began, the Indian Health Service did not have funding for emergency operations. So thinking about funding infrastructure and the consequences of that, they're really borne out all in one figure. But when we look at other figures and say, look at it by geography, so this is deaths per 100,000 Indigenous residents for the states that have available data. A few things. Let's start with on the right. There are some states where data isn't even available. We saw from the Urban Indian Health Institute that many public health jurisdictions would get an F on data reporting because they simply don't have data for American Indian people. But when we do have data, we see that the death rates vary drastically. So New Mexico, it was roughly 10 times higher than the non-Hispanic white population, but in areas like Mississippi, much higher. Montana, Arizona, North Dakota, all higher than other groups. But again, you see this wide variation where you kind of think about how the infrastructure across each IHS area is not necessarily the same, and responses also look different. This is data from the Brookings Institute. So again, age-adjusted death rates high among, this is where I actually can't say Black, Indigenous, people of color, but again, seeing the highest rates for American Indian people. Looking at state by state. So again, New Mexico for age-adjusted death rates, 10 times higher for New Mexico. And then through Montana, Arizona, North Dakota, South Dakota, and Oklahoma, consistently higher than the non-Hispanic white death rate. And it's not to say that each death is a tragedy, but to see such a stark difference in these rates is a tragedy in itself as it relates to data. And the data that we do have, we also know that it's likely an undercount due to issues of racial misclassification. This is the same thing, but converted into rate ratios. This shows the distribution of deaths based on age. So for the American Indian population, it was those in their their 40s, their 50s, their 60s who were dying, rather than for the white population, where you certainly saw those who were 85 plus who were dying of COVID-19. And what this looked like on a state-by-state level was you saw similar death rates for American Indians and Alaskan Natives for the white population that was 20 to 30 years older than any age demographic. So, if you're 55 and American Indian Alaskan Native, you had similar death rates to non-Hispanic whites who were in their 70s and 80s. And that was usually consistent in areas that had high American Indian populations. This shows the death rates by age bracket by state. So for those viewing, you can see it. Those here, Kanata, this is Arizona. This is Montana. New Mexico, where again, you see here for the American Indian population, they have a higher death rate than the non-Hispanic white population between 75 to 84. So, if you always took this area and compared it, usually 2 brackets over, you would see this being comparable or higher. And that was certainly something very interesting that came out when we had data that was being released. Again, other issues. So not new to COVID-19, but certainly prominent, is this phenomenon of being born Indian and dying white. So when you need a ventilator or more advanced pulmonary, respiratory, or just critical care to combat the impact of COVID-19, the IHS wasn't necessarily providing those services. Non-IHS hospitals and more trained personnel were doing that. And when you were sending our people away so that they could try and recover, they were not being marked as American Indian and Alaskan Native on their death certificates. So while we were born Indian, we die white. And according to a 2016 report from the American Journal of Public Health, American Indians and Alaska Natives already are 40%. 40% of them are likely to be misclassified on their death certificates. So not new, but again, a very prominent issue. We also saw other issues such as people making policies that restricted access to data for tribes to respond to COVID-19. We saw the IHS entering into dubious contracts for defective masks delivered to the Navajo Nation. You had the IHS shut down a birthing center in Phoenix in the middle of a pandemic. And you saw a hospital that used zip codes with high American Indian populations to take newborns away from their mothers because it was assumed that they had COVID just because they were Native American. I didn't really talk about vaccine hesitancy in this presentation because I honestly don't think vaccine hesitancy was a major contributory factor to COVID-19's impact in Indian country. In fact, we actually saw American Indians and Alaskan Natives more likely to be vaccinated than other racial and ethnic groups because we saw the impact that it had in our communities. And you saw people who took the time to sign up for research trials to make sure that it was available to our people. And we certainly saw targeted social media campaigns led by Native health organizations to get a vaccine because it wasn't taking care of just you, it was taking care of the community. And when we think about the kind of collectivist nature of our peoples, we would rather take care of our community rather than prioritize the needs of ourselves. Oh, that's exciting. Out of the presentation, there's been like no reactions and I get the one heart in the corner. So thank you for that heart. And then, so this is, some of the problems again that we saw, last year that were addressed. So, given that American Indians are dying below age eligibility cutoffs, what should you do? Tribes use their authority to prioritize tribal members and offer vaccines ahead of public programs. 40% of American Indians had difficulty getting to a clinic for a vaccine. So many communities went on the road to give vaccines, seeing how safe they were to give. Data wasn't available, despite a legal authority to do so. There's acts in Congress to reaffirm this authority and get access to data. So when you have limited data sharing, data misclassification, and a limited infrastructure, again, these are very distinct issues, but I hope that you've also taken away that they're very related. And this is just kind of the modern reflection of how systems are operating today to marginalize our people and make it harder to respond to issues of public health significance or public health emergencies like COVID-19, and of course, in the future pandemics. Another issue is the state of the workforce. We comprise 3% of the population, but only 0.5% of physicians and full-time medical school faculty identify as American Indian Alaskan Native. So it's really hard for students to go through medical education when they don't see themselves along the medical education continuum. When we think about disparities in matriculation rates, it looks just fine if you look at American Indian Alaskan Native. But when you disaggregate it using data, you see that the matriculation rate for some tribes is 10%, and others it's 25%. Others it's, I'm trying to find the highest one here. It's just to say there's a lot of differences. So, when you look at data, always think about the importance of disaggregation, because disaggregation tells a story and aggregation hides disparities. So I believe this is actually the closing slide, and that's actually on time. So the goal and what I'm really trying to highlight here is that when I think about equity, equity means Equity is about need and acknowledging that the need among groups is not necessarily the same. So when we think about getting resources to our communities, we don't have to fight for the same resources, but we need to make sure that each community gets the resources that they need. We also have to acknowledge that many communities have a different worldview, and we're not all focused on prioritizing the same things. So I'm sure we've all seen the ballpark equality, equity diagram that tries to get people to watch the game, but some people don't want to watch the game because they have other important things to take care of, and um, they don't necessarily think that it's not important, but it's not a priority for them. So when we make assumptions about what communities need without consulting them, we ourselves can contribute to those disparities. So in closing, if you only know one tribe, you only know one tribe, and you should also, reach out early and often and be a good partner. You should never approach a tribal community and say, here's what we can do for you, but instead you should ask the question, what can we do for you? And how can we be a good ally, a good advocate, and make sure that we are not furthering this negative history? Because we have a lot to contribute to society, but those contributions are often overlooked because of the assumptions that are made about us. So again, I'd like to thank the center here at Mayo for the invitation, and would love questions in the closing minutes if we have some time.
Perfect. All the questions just came. Grab a drink. I will too. A couple of questions just came in. Do you have suggestions about data classification?
So suggestions for data disaggregation classification is working with tribal epidemiology centers, centers for Native American health who have experience working with this data to make sure that you're also following good practices as it relates to tribal institutional review boards, as well as Indigenous research ethics. Good question.
What is up for vote now regarding data sovereignty?
What is one?
Up for vote now.
Up for
Vote.
So up for vote now is the Tribal Health Data Improvement Access Act of 2021, which reaffirms the legal authority of tribes to access data specific to their communities and make sure that agencies like IHS, CDC, and HHS have procedures for tribes to access their data. And that is currently has a hearing and has gone before Congress. So please encourage your lawmakers to support it.
What can or is being done about making IHS funds mandatory and not discretionary? Or will it ever be because other sites will go 638? Your thoughts?
There's a movement to secure advance appropriations for IHS first, and then eventually mandatory funds. The National Tribal Budget Formulation Work Group, comprised by IHS, says that a multi-step strategy to fully funding the IHS will take it from $9 billion to $50 billion in the next 12 fiscal years. And that would be full funding of the agency to actually meet their healthcare mission. And when we think about $50 billion, that also means more than what the NIH receives in annual appropriations. So again, when you have an agency doing so much with so little, what would it look like if it was actually funded? I think that would be a great reality for our people.
One more about IHS. As medical students, how can we advocate for more stability for IHS funding? Should we be prepared as physicians to apply for grant funding for the clinics we work?
I would love if medical students did that to help their clinics secure funds, but when acknowledging where students are in their training, the best thing that you can do is to create spaces for Native medical students at your own institutions, and also challenge your administration to make the curricula inclusive of American Indian health. I don't think it's controversial to say that all physicians and medical students should learn about Native health, not just Native students. These are issues that are important to all people. And the more you know, the more you can help out when you find yourself in a situation where that's possible.
So no more questions. Got a nice comment. I think it's a good way to end here. No questions. You did a great job. So proud of you. So, positive reaction.
Well, thank you, everyone. And please be in touch and connect if you'd like. I'm always happy to have a good conversation and also work to address these issues through health policy.
All right, we just want to thank you again, Alec, for joining us in person today. Thank you for that wonderful presentation and for making the flight over. So I just also want to announce, if you all can please take some time to fill out our short survey to provide feedback on our speaker series. You should be getting an email with the link, but you can also scan this QR code here and that will take you to the survey. And if you are interested in viewing any of our previous presentations, you'll find that on our website. Also, if you are interested in any of the previous PowerPoints as well, please reach out to me and I can get that over to you. We won't have a guest speaker for December. We'll restart in January. So thank you all again for joining us today.